Well, Daphne, that's a hard one to follow, but thank you for what you do. It's very important because I think in this epidemic, we've seen many champions. Your story brings back memories for me when I was working as a clinician in Zambia and faced at that time with a situation where we had so much desperation with the children that were coming in our care. In the pediatric hospital where I worked, over 40% of the children that were coming in under the age of 1 had HIV as the underlying cause of whatever they came in with. I saw kids that came in with what I thought was simple pneumonia and they were dying in our hands. But I also saw many faces of the people that were caring for these children. I'm a pediatrician, I believe in breastfeeding, but I saw mothers who were wasting away and babies that were wasting away, and the only comfort they had was that breast from the mother. And that used to kill me because I knew that breast was also filled with HIV. But that was the only source of comfort for both people, the mother and the child. But I also saw grandmothers that were coming in year after year with different children because their children had died. And instead of enjoying the grandmotherhood, they were now looking after children. I said no to that, and I said, we need to do something. And I became an advocate for change in my own country and started to talk about prevention of mother-to-child transmission from a very simplistic idea. I was reading a lot. Richard Semba had published vitamin A the association of vitamin A deficiency and HIV risk in children, and showed the association. So in my own humble way, I said, wow, maybe if we give these women vitamin A, we can reduce transmission. Because at that time, we're talking about $1,000 per woman treated in the US to reduce mother-to-child transmission. My own sister was a minister, and she kept telling me, you're crazy, we can never do this here. But we've come a long way, and this is a story to be told in terms of what we've achieved with mother-to-child transmission of HIV. So when I look at where we are with what we're talking about today, I just want to go back 1 year and say the global community has again committed. And this time we're saying we can end it. We can end HIV. Now, I'm an epidemiologist as well, apart from being a pediatrician, and it's harder than we think. HIV is a chronic disease, but we have the tools to really make a difference. And I think Daphne's story is a good one. And it's nice to see you up here and talking for yourself. This is what we want. We want these voices to make a change. But, okay, so we've got commitments. But what I think for me, and this is what I'm saying here, is how we come together as a people in the next 36 months. Because the targets that we have are very bold. We have for children targets for 2018. We have targets for 2020. When the high-level session was happening in New York last year, as we're thinking about what's the board agenda, what are we going to do, what are those targets, some of us said, for children, we cannot wait. So we're going to have a super fast track for children with targets in 2018 and 2019 and 2020. And when we talk about children, we're talking both about adolescents and children under the age of 10. So how we come together as a community, I think will give us the impetus that we need and in putting this epidemic under epidemic control. So in terms of the key points that I want to raise, I want to talk about adolescents, the situation where we are and why I think they're being left behind. Adolescents are still dying of HIV. I'll demonstrate that. It's one of the leading causes of death. We know that, especially in Africa. And our prevention efforts for adolescents are nowhere near where they should be, although we're starting to see the light, especially with some of the initiatives that are being put on the ground. And then Daphne talked about stigma and discrimination. it has to be part of what we do if we're going to move forward. So I just want to go over a few statistics, starting with where we are in terms of the burden of disease. So we know that we have up to 1.1 million adolescents living with HIV today, and 260,000 of them were newly infected in 2016. So we know that. But we also know that the spread of this burden of disease varies from region to region. Africa remains the most affected region. Up to 85% of infection is in sub-Saharan Africa. And here what I have is that out of the 2.1, 1.3 are in Eastern Southern Africa, which is about 63%. And then we have 450,000 adolescents living with HIV in Western Central Africa, which is 22%. That makes up 65%. But no region is spared from HIV. As you can see, it's a global epidemic that we have to face with. Despite knowing that we have 2.1 million adolescents living with HIV, we don't have good programs for delivering antiretroviral treatment to adolescents. In fact, I always say to my team in New York, I don't know, maybe I'm wrong, but in the countries that I've visited, there's no such a thing as an adolescent treatment program. What is happening actually is that we're starting to treat these children very early, and the transitioning from childhood to adulthood is where we have a problem, because first, the children themselves are not ready for that transition, because very few programs support them to make that transition. But even when you support them, my own experience treating sickle cell disease in UTH, University Teaching Hospital in Zambia, is that the kids get so used to you. You also get so used to them that the time of transition is not easy. They'll go and come back. They don't like to move from the care that they receive as children. And I think that is also manifesting itself in what we do for adolescent treatment. So today, only 41 countries report data on adolescent treatment. Not all countries even have disaggregated data for adolescents. And when we look at this data, and this is why I have the bars going up, each one of those dots represents the countries that are reporting. So the median for that is about 36% access. At a time when we have a lot of mothers, pregnant mothers that are getting antiretroviral treatment, is almost 2/3 of mothers today are getting antiretroviral treatment. In some countries, this is way over 95%. We're talking, World AIDS Day is coming up. I'm sure Michelle Sidibe will be releasing new data that 22 million adults are accessing antiretroviral treatment. We're making huge strides in treatment access, but not for this population. And there's reasons for that. So I just want to illustrate what we have in terms of HIV-related mortality. In the blue are the children, 0 to 14, and in the bottom are adolescents, 15 to 19. And you'll see what progress we've made with the children, 0 to 15. That is a 43% reduction as of 2010 that we're seeing in children. But in adolescents, it looks like a flat line, but it's actually increasing a little bit. It's the scale is what makes it look flat. This is nowhere where we need to be. It's totally unacceptable. And I think we need to ask why. When I sit in scientific conferences and I try to listen, one of the problems we have is even when scientific studies are done, they don't like to enroll adolescents. One, there are consent issues, but the other issue is that when you want to do a study, you want to have a good cohort that you can follow through so you can have validity of your results. Adolescents are difficult to deal with. So your attrition rate will be much higher than you wanted. So part of the problem is that we need to work with the people who are doing the research to give us the answers, and yet there are very few studies that are looking at this because of the problems that I've talked about. So what you hear in many conferences is to say, where we studied so many people and we got these results, however, the adolescents ABCD, right? And I'm sitting there and saying, but what did you do specifically to engage the adolescents and make sure you follow through? Because once they're part of an adult cohort, it means then the approaches that we are applying may not be relevant. And maybe some studies try to do that, but I still argue that we're not doing enough studies that are looking at adolescents and what we actually need to deliver services for them. Hence, this may seem like a small number, but I've already said it's increasing. Those are the number of deaths as of 2016, and the majority, 9 out of 10, is in Africa. What about new infections? So I've talked about HIV-related mortality, and I've also talked about access to treatment. For new infections, again, this is a slide that demonstrates what we've been able to achieve with mother-to-child transmission. And this goes back to 2010, which is now a benchmark for the new targets that we have. And the blue line is the adolescents. And you can see that for the 0 to 14, we've made remarkable progress. That translates to a 47% reduction since 2010. And what we have for adolescents is that as of 2016, there were 260,000 adolescents newly infected with HIV. And when you look at the trend line going back, actually, in the last few years, there's been a stalling in new infections, and the reduction is less than 5% per year. And that's concerning because we've heard about the youth bulge and what's happening with the demographic dividend. This is analysis we've done looking at the data that we have from UNAIDS. The reanalysis by my team in New York has looked to extend the line from 2016 to look at what will happen up to 2030. So if we continue at the current trend of decline, the red line, the bottom lines disaggregated there by age, the bottom lines are where we're going to be. And you can see that we're starting to see an increase. But if we don't step up the pace and there's a stalling in investment in this particular age group, there'll be a much bigger increase in the number of new infections in adolescents. And we haven't even factored in the youth bulge in that. So the issue for me is that if this is our future, I don't know whether it was the minister that talked about the adolescents being the future or somebody else talked about that. But if this population is our future, I think we are all duty-bound and obligated to make sure that we respond to the needs of this population. Now, as we think about this, context is going to be very, very important. We have to know who are the young people that are being infected. And this is just a simplistic slide that I've made, which looks at the regional distribution of adolescent new infection, and looking at the green is adolescent boys and the red are adolescent girls, and how that's spread out across regions. The top 3 regions are Eastern Southern Africa, Western Central Africa. I was actually surprised that Eastern Europe and Central Asia is also very much a female epidemic. So that's important because as we think about how to do this, it's very important to target. UNICEF in the past has programmed for adolescent HIV mainly by focusing on life skills education as the way to do it. And we're heavily criticized for having that generalistic view because, first of all, not all children are in school. What about those that are out of school? But we're also criticized to say, how do we know we're hitting the right adolescents with the right information for us to make a difference? So we moved away from that focus, although we still do life skills programming, and we're really more focused on making sure we have the right information to target our interventions better. My recent experience recently was with Thailand, where we were thinking about starting up a PrEP intervention, pre-exposure prophylaxis. Now, Thailand, that intervention we wanted to do in adolescents that have sex with men. And the starting point is even to define who are these adolescents. So that was the starting point. So we worked with the ministry in Thailand and said, do we know how many of these adolescents that we have here are MSM? They came up with a ballpark figure of 3%. I don't even know where that came from, but they said from the different studies, they think it's about 3% of the population of adolescents are MSM. And then the second thing they said is 1.5% are transgender. When we started to look at the provinces where we needed to do the work, they just said, just use the 3%. So that's the starting point also. But I also learned a lot from my PEPFAR colleagues as we are having this conversation, because they said to me, Chewe, how are you going to do this program in adolescents? Because these are young people, first of all, who are starting just to think about their own sexual identity. A lot of them have not even revealed it to anyone. They don't even know who to talk to. So what intervention are you going to put in place to find these kids? That's when I said, oh my God, they're right, and started to think through, how do we do this effectively? So data is going to be critical, and understanding who these populations are is going to be critical. Now, when you look at children through the life cycle again, you see that there are differences. Children are not the same in terms of who's getting affected. When you look at the bottom bars, the bottom part of the graph looks at children below the age of 15. And what you see both in the rest of the world and in sub-Saharan Africa is that the green and the red are very similar. So these are vertically infected children, so we don't have much of a gender disparity. But from 15 years on, you look in the rest of the world and in Africa, you start to see the differences of who's actually being affected. So you find that in sub-Saharan Africa, this epidemic is very much got the female face in terms of new infections. And we start to see that from age 15. And so the importance of adolescent girls and young women, and the fact that the peak incidence is in the age group 20 to 24 is extremely important. And I was in the Durban conference when Karisha and Sarim and Karisha actually published their data looking at the cycle of infection and centralizing the importance of adolescent girls and young women, who is infecting them, and who are they getting married to. And it was very clear that they're getting infected from much older men, and now there's good analysis as to what that age band is in terms of risk, and that when they decide to get married at age range 20 to 24, they're getting married to their peers. So you see that infection rates in adolescent boys is much lower than girls, but the girls are going to get married to the young men as they become older, and that cycle continues. And I think that's important because it starts to tell us that even if we intervene in the girls, if we don't intervene in the people that are infecting them, then the cycle will still continue. And so the importance of making sure even our treatment program is targeting that age group of men to make sure that their viral is suppressed and they don't infect the girls, extremely important. But also the circumcision program in Africa has to target that population so that they're not infecting the girls. So what you start to see are the shifts in what will make our programs much more effective. And that's why we're saying maybe we can end this epidemic if we just apply the knowledge that we have appropriately. But this is the picture in adolescent girls and young women. This is an analysis that we've done at UNICEF looking at the trend line of where we are now, 360,000 new infections in 2016, with an annual reduction rate of about 3 to 4%. And if you pull that line, where we're going to be in 2020 is 320,000 new infections. What has been set as the global target is 100,000 new infections by 2020. So you can see the gap that we're nowhere near, and yet we have the tools to actually change that trajectory. But the question is, what are we going to do to make that difference? Part of the problem with this picture is that when you look at the knowledge, understanding of these adolescents in terms of HIV information, this is just data from our DHS and mixed surveys looking at this. And really, we haven't moved these bars, despite what we've been doing all these years. Why is it that only 27% of girls actually have comprehensive knowledge when you look at across the countries that have recently done mix? So whatever tools we are using to communicate probably is not reaching this population. And so part of me is saying, what is it that we need to do differently? I think it comes back to the point that we don't understand adolescents and we're not involving them, and we're using generalistic approaches to get information to them, and it's not reaching them. So I think this is one of the things. The other bars there are looking at, in the middle is condom access in terms of condom use in adolescent boys in green and adolescent girls in red. And the last one is HIV testing. So you can see that the data across the board is really, really bad. And this is the question Mr. Lake is always asking me, my executive director, what is it that we're not doing? And I think, for me, I think we're at the crossroads and we need to make sure that we do make those changes. So in summary, I'm actually saying, as part of this presentation, is that we're nowhere near the targets that have been set, and we need to start doing things differently. So we have an opportunity, and what I have here is all the commitments that we have, the initiatives that we have. We need to all work together to try and push this agenda forward. And that's why when I started, I said, your presentation, Daphne, took me back many years. We were as gray in 2000 on pre-PMTCT, but we made it happen. So I think we just need to have our collective efforts to try and make it to happen. And so just to fast forward then, in 2016, my own executive director, Mr. Lake, approached Michelle Sidibe and said, we need to be all in on adolescents, and we need to make sure that adolescents are at the center of our response. And so we did launch a partnership with UNAIDS in Kenya, which is called All In. It's really about galvanizing all those people that I had on the previous screen to make sure we do have a comprehensive response to adolescents, and also work with adolescents at the center of that to make sure that we have the voice and they can tell us what to do. Alignment to the 90-90-90, I've told you about how far behind we are, even with data on treatment of adolescents. And on the data piece on treatment, I also have a story to tell. Recently, I met with Elton John Foundation. They've been reading the publications that UNICEF puts out, where it's saying, oh, there's a tripling of mortality in adolescents, or adolescents are being left behind. So they decided to make an investment in that area. And the interesting discussion I had is that they just literally took our data and said, well, okay, we're going to go to 4 countries and try and make a difference. What they were telling me when I met them in the office is the reality on the ground. So we're very good at putting out data, but you have to go in the country and make a difference. And what the Elton John Foundation told me is that, Chewe, we're working in Kisumu, we went in Kenya, decided we're going to go with the high prevalence districts or whatever counties in Kenya. And we've been testing how many children coming through the clinics. We've gone to the communities. We can't find these adolescents that you're talking about. And the reality is that the numbers are not huge. But the reality also is that it's possible that the 2.1 that I talked about, some of those are already in the pediatric cohort. The reality is also that they're probably going to places where other people are working. And so they're pulling the kids out of the cohort. And the reality is that maybe the spread is also thin. So it comes back to how do we work together really to have effective programs that are informed by what everybody else is doing. You can't do it alone. At this point in the response, they need to be talking to PEPFAR, they need to be talking to whoever is on the ground to try and define how to do it. So that's the all-in framework, which is basically pulling everybody in, but also making sure that we respond most effectively. And we have 2 targets in this all-in framework: reduction of HIV-related mortality by 65% by 2020, but also reduction of new infections by 75% by 2020. And in the middle there is we have to do the treatment and we have to do the combination prevention, but also we need to have the enabling environment and the social factors and support that will make it happen. What is important and good is that coming out of the high-level forum, as I talked about, we did talk about super fast tracking for children, and we have clear targets. What is very exciting for me is that building on the success of the global plan to eliminate mother-to-child transmission and what we've been able to do when we've all come together, clear targets, clear strategies, clear plans, costed, donors, Global Fund, PEPFAR behind it, what we've been able to achieve. And so building on that, we've also come together on this super fast track, 3 freeze agenda. Start free, which is elimination of mother-to-child transmission. Stay free, which is prevention of infection in adolescents and young women, adolescent girls and young women, and AIDS free, which is about the pediatric treatment. So as a way to bring it all together, and our strategy to end AIDS in children is exactly this, that we have to work around prevention, we have to work around treatment of kids, and we have to work on elimination of mother-to-child transmission. And we have the clear targets that I have there that I don't have to go through. So how is UNICEF responding to this? I became the UNICEF director for the AIDS program in 2016, last year, at a time when we're having a lot of challenges with everything else that's happening in the world. I mean, the migration and all that, when our resources as an HIV program were really going in the wrong direction. So Mr. Lake said to me as I entered into this job, said to me, you have to now to define how we're going to move forward, given the resources we have and the human capital that we have. The good news is that UNICEF decided HIV is going to remain an important part of our work. So part of what I had to do then is how do we recalibrate? And what I talk about when I talk about the UNICEF program now is that it's not going to be business as usual. It has to be data-driven, it has to be evidence-based, and it has to be built on real partnerships with people that are affected, but also with what everybody else is actually trying to do. So when I talk about the data-driven, the all-in framework, one of the things that we've been able to do successfully is that we went out and said, we can't continue to say there's no data for adolescents. Let's go into the countries and find it. So one of the things that we did is to galvanize the partnership and governments to actually sit around the table and say, what data do we have? What's the situation of adolescents? But also critically important is to look through the various lenses, what is happening in that. So this example that I'm giving you is from a work that we're doing with funding from Norway and Sweden. 4 countries. 4 countries, one was doing very well on elimination of mother-to-child transmission, which is Malawi. Uganda, at the time we started, was lagging behind Malawi, but they had decided to go treat all approach for pregnant women at the time we started. And then we had in there DRC, which was very far behind. And we had in there Cote d'Ivoire that was also not doing that well. But this data is from that work, and this is what I'm talking about when we talk about adolescents and how we respond. In a program that's doing very well, which is the PMTCT program, adolescents are still left behind in terms of access and in terms of retention in care. And that's what I have here is just looking across the countries. If you look at the bottom two bars, it gives you an idea in terms of the bottom one is percentage of adolescents that are coming into treatment already on pregnant women coming into PMTCT already on treatment. The red bar is the adult women. The blue bars are the adolescents. Okay? And then the second is looking at of those mothers that are started on ART, not antiretrovirals for PMTCT, what proportion are adolescents? And you can see, not what proportion of the population of adolescents in those clinics are actually on treatment. Again, you see that I don't have confidence limits, but you can see the pattern there that in the two countries, DRC and Malawi, the adolescents are not doing that well. Now, there's been other studies that we've done now with CDC Atlanta, looking at this and demonstrating the same thing, that access in adolescents is much lower than in older women. The second is on retention. The red bars, this is retention defined through various lenses, within how many? Within 90 days, within 6 months. And you can see in the red, that's the adolescent bar, and in the blue are the adult women. Again, when you look at retention, you find that by, if you look at how many adolescents completed 6 visits, 43% compared to 50% in the adult women. Retention is a problem overall, but it looks like it's worse in adolescents. So as we go into this, I mean, I think what I'm trying to illustrate here is the power of data to sharpen what we're trying to do, and we need to do better at that. I just gave 2 examples, but I think what is important as we look at the data is what are we going to do, so which is we need to find new ways of reaching these adolescents. Well, obviously, our clinics are not doing a good job of it. How do we do this? And I've just got 2 examples in this slide, looking at some work we've done at community level in South Africa on HIV testing, and also in Namibia, school-based testing. And you can see for both approaches, we're actually doing much better than the general testing rates in the country when we use other approaches. Very quickly, this is another example of work that we're doing in Brazil, where we're actually going out using mobile vans to places where adolescents congregate and actually doing HIV testing through this modality with support, peer support from adolescents themselves, and achieving very high rates of testing coverage. Apart from looking at approaches, we're also saying we need to innovate also, and we need to make sure that as new tools become available, adolescents are also part of the program. At the time when WHO released its guidelines on PrEP, we were very concerned as UNICEF that adolescents were not in there. And part of the problem at the time was related to the fact that the data on adolescents was not good in terms of retention in care. But we argued that that should not be the reason not to include them. But of course, there were people that felt we might create more problems than good, but by including a cohort of people that we know will not adhere to the intervention. So we convened a meeting of experts, the scientists themselves, and also program people from countries at the last meeting of the International AIDS Conference that was held in Vancouver. And so out of that meeting, there was general agreement that we needed to include this cohort of people in PrEP services in countries. And we actually gave a direction as part of the meeting report. And we're very pleased now that many countries are now including adolescents. In fact, we're having trouble. I talked about us wanting to work in Thailand. We actually haven't started that program in Thailand as UNICEF because we found that PEPFAR had already decided that their PrEP investment in that country should now include adolescents. Then we said, well, what's then the value add of us going into Thailand to do this? It's all good, and Global Fund is also coming in with a huge program of PrEP, and they're going to include adolescents. So what I'm trying to demonstrate is that we don't always have to do it, but if we bring the right people into the conversation, we can make a difference. Adolescents are agents of change. I wanted to just give you another example of how UNICEF is working with adolescents. This is called the U Report. It's an SMS platform that crowdsources youth to the platform so that they can talk to each other. But we can actually generate areas or thematic areas of conversation with them. Like in Zambia, the whole program was focused on trying to get more adolescents accessing services. So the conversation on this platform was around treatment, around the importance of HIV testing, the importance of circumcision. And what we're trying to get is, first of all, their views and opinions, but two, their experiences, so that those that had done it could actually talk on this platform so that others could hear it. And that data then can be analyzed, but can also help inform better programming of the people that are providing programs. So I think we need to find adolescents through ways which they like. And so for me, Snapchat or whatever they are, I think we haven't tapped into those things adequately to make a difference. I know I've spoken a lot. I just want to end by saying that we really need a differentiated approach, targeted approach to reach adolescents with services. And I think making sure that context is also taken into account and data is taken into account is going to be critical moving forward. I want to end by just thanking, again, Irish Aid and for actually the work that we do with them. They've been a long-standing support for UNICEF work, and they serve on the current executive board of UNICEF. We need the voices around HIV, and I hope that they can continue to do that. They are one of the top 20 international donors of UNICEF work, not just HIV, and I have some numbers there of what we got from Ireland for 2016. And I think I was being reminded that for a small country like Ireland, this is a lot of money, and we value your contribution. And I've got a few more numbers of the work that we've done, but I think the more important I want to say is that we've gone through a review process of the global AIDS response under the leadership of UNAIDS. And one of the things that has come out of that review process is the focus on country to make sure that we are all joined up in what we're trying to do to reduce redundancy, but also reduce duplication for impact. And I'm in favor of that type of approach. We are at a time in the AIDS response where we really need to have collective action if we're going to end the epidemic by 2030. In summary, I want to say we can and must change the course of the epidemic, especially for adolescents. So thank you very much.